Apologies, we're slightly late there. Just reminding members again to switch off all mobile phones or Blackberries, so they'll interfere with the equipment. I have apologies from Roy Biggs. Any other apologies?
Chairperson, I have to leave before 4 o'clock, so never get on.
Okay, thank you. Under Chairperson's business, I want to refer members to the draft motion on health inequalities, specifically looking at people who experience learning difficulties. It's on page 7. If members just indicate, are they content with the motion as drafted?
Yep, happy enough.
Okay.
Great.
Okay, thank you, members. Also want to just advise members, obviously, that the Department of Health received 30 million in the January monitoring round, just announced yesterday. But there isn't any precise details at this point about how the 30 million will be allocated across the different priorities. It had just indicated in the statement that it was for a range of pressures. I'm suggesting, members, that we would write to the Department to seek that clarification on how it would be spent. And I think it is important as well to note that the Department originally bid for 65 million. 20 million of that was suggested to be for clinical negligence. So that ultimately means that 35 million of the bid wasn't met. And I think, members, it would be useful to ask the Department how they intend to fill that gap also. So are members in agreement with that? Also, members, it doesn't seem that the Department has been able to secure the executive approval for a legislative consent motion on the standardised packaging of tobacco. The committee had agreed, quite rightly last week, that the position is that we would favour the LCM in principle, pending obviously the sight of the actual wording. There is concern, therefore, whether the Department will meet this deadline of the 4th of February, and whether it's still then going to be able to meet the House of Lords deadline in relation to the legislation. I'm suggesting, members, that given the urgency of this and the very vocal lobby over the last few days on the media, that we write to the Department seeking that update, whether it is intended to meet that timeline or whether any other urgent procedures can be used to ensure that we have this LCM passed and approved. So if members are comfortable that we write and seek that update.
Great.
Thank you. I also want to refer members to a letter from the Children's Heartbeat Trust at page 3 of your table papers today. When it refers to a recent incident, as members may be aware of, where a child was transferred to England for treatment, and unfortunately there was problems identified with the aircraft. And whilst we are all clear that it's not the committee's role to become involved in individual cases, I would suggest that we seek clarification from the Department. I have raised this with the Department on the wider issue. There is to be a review by the board in relation to this aircraft. Certainly the family have indicated that it was substandard and inadequate. So I suggest we write to the Department to ask for an update on that review, to furnish the committee with the findings of that review, and to also ask, in relation to the wider issue about Children's Heart Services, whether arrangements have actually now been put in place so that consultants based in Dublin can assist staff in Belfast, so that the surgery can be provided in Belfast while the independent review is ongoing.
So just worth making the point that even if we do get a resolution and have a service in Dublin and Belfast, there still will be a significant number of children from Northern Ireland and indeed the Irish Republic having to be flown to England, because that is for extremely complex procedures which cannot be carried out in Our Ladies or in the Royal. So, to say that the review will lead to a solution to this problem, it won't. We will never get to a situation where all the children in the Irish Republic and Northern Ireland will be treated on the island of Ireland. That simply won't happen. So therefore, I think the issue here is that whatever vehicles they're used to take them is adequate and up to standard and safe. And I think it's wrong to lead people into thinking that what the review is doing at the moment will lead to a stop to the situation developing. It won't.
Well, I think, with respect, hopefully the review will find a solution of some description. I take your point, and I think there are very complex cases that surgery may be required elsewhere, and I think all of us would accept that. However, I think the issue here remains that there was to be procedures and processes from the Minister's statement on the 9th of December put in place between the Belfast Trust and Dublin. And I think that that's what we're seeking clarification on. Have these processes and procedures been advanced? Are they in place? Were they just not feasible in terms of this particular case? I think we need to get a sense of that. But I take your point, Jim, that there are more complex cases as well. Yes.
Chair, I totally agree with what's been said, but I mean the story as it unfolded was absolutely shocking, disgraceful. That a mother would be put in the position that we seen getting into an aircraft, despite the fact that, as I understand it, the authority said it was safe. I don't think if I had been asked to go into an aircraft like that, I would have went, let alone a mother distressed with a baby in serious conditions. So I think there's got to be questions asked about. We've all been talking about an air ambulance for Northern Ireland or for the whole of Ireland, and yet we've been that patient has been allowed to go through that ordeal. And I think we must, as a committee, I would hope that everybody would agree that what the patient had to go through was wrong and should never have happened. And I hope it doesn't happen again to anybody else.
Okay, Mickey.
No, I think the difficulty for somebody in that position, you don't know how bad it is to get on with. And presumably, you're in a situation where you're going to say, hang on, this plane is inadequate, so stop it. I mean, who knows? We all get on the aircraft, you don't know whether it's good, bad or indifferent. Obviously, if you see a hole in the door, you might think there's something untoward. But, I mean, you're in that situation, and really, they need to supply a vehicle or an aircraft that is appropriate and adequate for what it's intended for.
Okay.
Because those people were probably in an impossible position anyway. Who do you complain to when you're taxiing down the runway?
David first.
Chair, I think that your initial suggestion about the advancement of the arrangements, I think, is a very valid question. I think that's fair. I think we should all unite around that. The issue of the aircraft, and I say this as someone who has some considerable flying experience behind the wheel, a faulty aircraft is the role and remit of the Civil Aviation Authority and them alone. And if we have an issue with the aircraft, well, it's really them who should instigate an investigation. And if the family have an issue with the aircraft, then they should be the one who instigate the investigation. So I really think, I know obviously there was an issue, the aircraft was the headliner on this particular story. But quite honestly, if the authorities and if the Civil Aviation Authority deemed the aircraft to be fit and safe, then they are ultimately the patrolmen of the skies when it comes to the safety of aircraft. So I think we are possibly slightly overstepping our mark if we're going into that territory. But I think we do have to, the question over an advancement of the processes, I think, is a very fair challenge. But I think, if we write to the department asking for something around this aircraft, they will probably just come back and say, well, it's Civil Aviation Authority.
Well, just for clarification, I spoke to the department this morning, and there is a review, and it is the Health Board that are conducting that review, and the department were meeting on it today. So, I mean, all I am asking here, and I take your point, David, that this is a company, effectively, but there is, the Health Board are conducting a review. I'm asking that we're furnished with the findings from that review.
Which is fair.
Yeah, thank you. Fergal, then on the
just to follow on, I mean, if there wasn't something wrong, then I would expect that the department and others wouldn't be making a big issue of a replacement craft, which is of some improvement, I understand. But neither should the issue of the replacement take away from the substantial issue around how our very vulnerable young children are being treated in relation to their conditions. And I appreciate what Mr. Wells is saying, but we would hope that were there to be a wider substantive settlement of that, the issues around that, then that would reduce the need for the air ambulance situation on both sides of the border.
Okay, thank you, members, for that. Moving on to the draft minutes of the meeting on Wednesday, the 15th of January. Refer members to the minutes on page 9. Are members content
Great.
Thank you. Item 4 is a review of waiting times. An evidence session with Professor Charles Normand. I think Leanne is just... You're very welcome, Professor Normand, Professor of Health Policy and Management at Trinity College Dublin. The procedure here is just if we asked you to make a short 10-minute presentation, then we'll open it up to invite questions from members.
It's great. Well, thanks for inviting me. It's nice to be back, and it's nice not to be talking about death and dying, which has seemed to be what I've spoken to you about on previous occasions. I'm sorry if I'm going to be slightly diverting into some general principles as well as the experience in the Republic, because I think it's useful to understand some of the underlying problems as well as trying to look at the specific experience. As people will be aware, as in most jurisdictions in the South, there's been significant concerns over a very long period, over long waiting times and long waiting lists, particularly for elective procedures. And the population, about 50% have private insurance, which allows them to some extent to jump the queue and get ahead. But the other 50% that doesn't is seen to being particularly disadvantaged. And the other complication is that the same doctors may well be doing public and private work, and there are some interesting problems around those incentives. Indeed, people can be paid or not paid, depending on the nature of the patient, not on what they're doing or where they're doing it. The hospitals are paid mainly on the basis of block grants. You get given money for a year in a budget to run the hospital, and the service agreements that go with that are really quite vague at the moment. Essentially, hospitals are told to be a hospital. They're not told to do particular things. And there's a mixture of public and private organisations and voluntaries in the system. I'm sorry about the top of the second page, but every time I kept thinking about what message I wanted to leave with you, I decided it was the same message, so I repeated it a lot of times, because people are constantly looking for the simple answer here. And my main message, if I have one, is don't. Because it's a complicated problem and it's got lots of parts to it. And if you think you're going to solve it by finding the right answer, you're going to be disappointed. You're going to have to find lots of right answers and do it carefully. I wasn't sure if it was different saying it was not simple from saying it's complicated, but it is both of those things. I think it's worth having a little bit of thought about what waiting lists are, because getting onto a waiting list and getting off a waiting list are the two things that happen, and what you're left with is those who got on but didn't get off. And I think it's important to understand that, because very often people only look at the getting them off without looking at how do people get onto the waiting list. And indeed, I was on a waiting list once at this excellent hospital in Dundonald. And by the time I got to the top of the waiting list, I couldn't remember which knee it was that gave the problem. It was only about 23 months between being referred and getting the appointment, and I'd lost the place. So I think it was an interesting example of how a waiting list may not really be a waiting list, and it has to be thought about and understood quite carefully. And I think it's also important to understand about waiting to wait, because a lot of waiting times you see are actually the times after you've waited to wait. And to be very clear about where we start the clock and where we stop it. There's also a difference between being told you're on a waiting list and told you've got an appointment, but it won't be for another 6 months or another 9 months. People are much more resistant to the uncertainty that goes with being on a list. And also there's a question of who owns the waiting list. Is it the people who are commissioning and paying for care, or is it the people providing? Because if you're a hospital and you're told to provide 4,000 procedures and you produce 4,000 procedures, in some sense it's not your fault that you didn't produce 4,500. And if there were 500 waiting on the list, then that will be the difference. So I think, again, we need to be quite clear about who owns the problem, because often people think about the hospital owning the problem, but very often the problem is also around the resources and the way that people are given expectations. And the other thing to understand is that some people like waiting lists. And we tend to forget that. But if you're a provider of care, nothing gives you a boost quite like knowing the resilience of people waiting to see you. And I mean, I understand that. I mean, I hate it when I've got such an easy diary that people can see me tomorrow or the day after. I want them to have to wait 3 weeks for a 20-minute slot. And I think we've got to understand it's not always against people's interest for a waiting list to be there. It can be good. So that's a little bit of background, but I think we also have to understand in any of these initiatives that a lot of it is to do with the incentives and the consequences. And often we produce incentives we never intend to. And the 3 initiatives I'm going to be talking about are, in some ways, victims of those problems, that people didn't understand the incentives they were creating. And waiting lists also can be just a way of rationing, as I described. In fact, it was a waste of time, my going to the Ulster Hospital when I did, because it was impossible for them to do anything useful. But because I'd waited for a year and a bit, I just thought I'd find out what it was like. And sometimes it's used as a rationing device, but it's a bad rationing device, because it doesn't really discriminate well. It's also sometimes a way of being dishonest, because you say, I'll put you on the waiting list knowing there's no chance of you getting to the top. And that's just a way of getting rid of someone. It's like giving them a prescription. I'm sure you're all aware of that. It's a good way of finishing a consultation. It's a way of avoiding hard choices sometimes because you can pass the problem on. And it is, as I say, a complex interaction between the referral process and the treatment process. And we tend to only look at the treatment end of that. So there were 3 initiatives in the Republic that were trying to do something about this. The first of these was the Waiting List Initiative, and then the National Treatment Purchase Fund, and thirdly, the Special Delivery Unit. Now, I'll just talk a few minutes about each of these in turn, but the Waiting List Initiative was a fund that was set up that paid hospitals that had long waiting times to allow them to do more treatment. And it seemed on the face of it quite a logical thing to do. The monitoring, though, was relatively weak, and it's hard to assess how much effect it had in terms of reducing waiting times, but one of the things that was quite clear about it was it produced very strong incentives to underperform, because if you could get your waiting times longer, you got more money. And one of the things we've got to recognise is people who run healthcare organisations are not stupid, and if you give them more money for doing it badly, some of them will do it badly. And this was very much what we found in this case. So the Waiting List Initiative was replaced later, and I'll talk about that in a moment, because it was producing the wrong incentives. It rewarded those who underperformed, and it therefore appeared to penalise those who did a good job. So if you give extra money for fixing a problem, you may well find that that is not, in fact, the way things work. You make the problem bigger in order that they can fix it better. The National Treatment Purchase Fund was a reaction to this, and it said, well, we're not going to reward the bad performers. We're going to give rights to patients. If a patient has been waiting more than 9 months or whatever the designated period was for some particular procedures, then you are eligible to have almost immediate treatment under the National Treatment Purchase Fund. And that would buy you a treatment either initially in a public or a private hospital or abroad. Latterly, they made it really only in private hospitals or abroad. And this meant that if you were a long waiter, you got immediately access to care. And certainly the results of it initially were very similar to the Waiting List Initiative, but once they abolished the access to public hospitals on an accelerated basis, that problem seemed to go away. But the real question then came out was, really, was it good value for money? Because it was effective at reducing waiting times, but at what cost? Now, I tried, and you can see in the report some estimates that came out of the Public Accounts Committee, but I tried to find out what the spending was. But of course, it was described as commercially confidential, and therefore I wasn't allowed to know. But I reverse engineered from the information we had what the likely costs were. They varied between being 20–30% higher than the cost of doing it in the public system to being about double. So there was a big range. But the thing that was quite clear was it was much more expensive than the treatment would have been had it been done under the original normal public system. Now, so The other criticism, though, that came of the Treatment Purchase Fund was it made it permanently okay for the system to underperform, because whenever it underperformed, you had a solution. So people didn't complain, and there was no pressure on the public hospitals to do anything much about it, because there was a solution offered that didn't involve them any pain or discomfort. So the Special Delivery Unit was an idea that was going to be combining the Treatment Purchase Fund with a fairly macho, aggressive approach to trying to improve the performance of the public hospitals at the same time. And they brought in a number of things. I'm sure you've heard of people advocating traffic light systems. Whenever I see a traffic light system, my heart sinks, because I know it's going to be simple-minded monitoring that will tell you you're green, but you can be green and not very good, and green and very good. And you can be amber and fairly good, and amber and terrible. So, I mean, I've always thought those kind of things were kind of crude, but it brought in that kind of measurement, were you a good performer, as well as, at the other end, if there were people who were waiting too long, they got swept into what was effectively the Treatment Purchase Fund continued. And but they also introduced some new rules about the longest waiters were the people who got the first priority. So if you were a short waiter, you would be kept waiting, however important your treatment was. If you were a long waiter, you got the treatment, however unimportant it was. And the idea was we'd get rid of the very long waiters. But what we managed to find at the end of that was the average waiting time went up, the maximum waiting time went down, and the minimum waiting time went up. And people turned out to be treated on the basis of when they joined the waiting list rather than on any sort of basis of need. So while it solved the problem of the very long waiters, it created another problem of unreasonably long waits for people with very important needs that were not being met quickly. And it was working on getting people off the waiting list, but it did nothing to stop people getting on the waiting list. And I think that was another problem there. So if I can just try and get some overall learning from these experiences. The first is that in each case, the providers and the users of the service responded to the incentives that were there. And that was both the intended and the unintended incentives. The other thing that became clear is there was a lot of gaming of the system. Now, if you know that waiting lists are very long, people will be put on the waiting list early, so that by the time they really need the treatment, they'll be ready for it. So, for example, if you have a cataract, and it's not yet ready for surgery, but it will be perhaps in 2 years' time, and the waiting list is 2.5 years, the logical thing is to be referred onto the waiting list early. And there's a lot of evidence that that was happening, that because people knew there was a long wait, they were anticipating this and working ahead. And also, and it's rather similar to a problem I dealt about 25, 30 years ago, before some of you were born probably. I was working on a project at the Royal Victoria here in Belfast where we were trying to reduce the waiting time for knee surgery. And we brought in people on Saturdays and they did lots of extra work, and it was all a great scheme. And after 3 months, the waiting list was longer. And the explanation was very simple. The word got around the GPs in Belfast that waiting times for knees were now going down. And so there was a flood of new referrals onto that. And we looked at it, and there was just a huge increase in the number of referrals because people thought it's not worth waiting 2.5 years, but if you only have to wait 3 months, that's good value. So you have to be very careful to look at what the effect of success is on the behaviour of people doing the referral, and we saw some evidence of that. But waiting lists really come from either the package being too big, that's to say, too many things are promised relative to the resources that are available, or because there's too little funding to cover what we're promising, or because the provision is inefficient, or because the priorities about who gets the treatment are wrong. And I think we've got to understand all these different things are interacting in causing the problem. So what can we learn from the Irish experience in this? Well, first of all, the initiatives were brought in without adequate understanding of what incentives they were going to produce, and they produced some intended but also some unintended incentives. And they didn't really understand why the waiting lists had got long in the places they had, and therefore it wasn't surprising perhaps that the effects were not always what had been hoped for. The refusal to determine what the entitlements are, refusal to do explicit rationing, which explicit rationing is always an alternative to the implicit rationing, meant that we had essentially implicit rationing through the misuse of the waiting list system. The problems were both of funding and provision, because when there was inadequate funding to commission the amounts of work that were needed, then one of the effects was obviously that waiting lists got longer. But also they failed to recognise that some people benefit from the longer waiting lists, and indeed, if you are helped when you have a problem, you're encouraged to have a problem in order to be able to get the help. And another thing I think we learn, and this may be a good lesson given that the health system in Northern Ireland is relatively simple compared to what it is in the South, the more complicated the system, the more difficult it is to introduce incentives and initiatives that are likely to work, because they will have these curious feedback loops that lead to the wrong thing happening. And where you've got a large private system interacting with a large public system, you tend to get difficulties of the wrong incentives being generated. And we did learn very clearly that people respond to incentives that are there and never think that people are going to be sentimental just because they work in the health system. If we produce strong incentives, they will, to an extent, follow those incentives, and we saw clear evidence of that. So if I have a message, it's very complicated. You won't solve these problems instantly. You have to look at both how you get onto the waiting list as well as how you get off. You have to look at the efficiency and inefficiency, but you also have to look at the adequacy of the resources relative to what you're asking people to achieve. And you've got to be very clear that if you generate incentives, people will follow them, even if, in principle, they're good people and they're trying to do a good job. Nevertheless, if you reward inefficiency, you'll get inefficiency. If you reward perverse behaviour, you'll get some perverse behaviour. So thank you for your attention.
Thank you for that. Professor, I think that, well, obviously the committee's taken a keen interest in this, and I think it is interesting that your analysis tells us that there wasn't an understanding of why lists were long in the first place. And one of, I suppose, and we're only in the middle of this process, but one of the messages that we're getting is sometimes this is about how the information has been collated in the first place. And, you know, there's a suggestion that we need to look at the total patient journey time.
Yeah.
I don't know if that has been a similar experience. And we have looked at, just through our assembly research structures here, what happens in other European countries. We've looked at Portugal, and we've looked at different voucher systems and patient and incentive systems, and also are looking and are going to take evidence from Scotland's experience in this. But it also seems to be that enforcement is the key. Would that be your...
I think it is. I mean, proper monitoring, proper evaluation of these things is important. And of course, one of the other lessons is, to some extent, people didn't want the initiatives to be evaluated too closely because it might well show they weren't working as planned. And too much information can be difficult and embarrassing when you're trying to do this. And certainly the Special Delivery Unit was set up to be sort of light on its feet and responsive and quick. But one of the things that went with that was there was no very careful monitoring of what they did and what effect it had. And I think that is a very important message that comes there. And I think, again, people were sort of hopeful that there was a quick fix and there was an easy fix, as opposed to recognising the fix is probably 7 or 8 different things. A lot of it has to be bottom up. And again, there was a tendency to go in and say, here's some answers, go and do it, rather than going in and saying, here are some things you've got to work on to improve, and try and work through that.
And just, excuse me, just I'm interested as well on one of your slides on page 4, talks about the initially treatment was in both public and private hospitals. I suppose that's one of the models that we're looking at, particularly European models about incentives, which are effectively private treatment.
Yeah.
And your analysis there that later it's mostly taking place in private hospitals or abroad, and that's more costly?
It was definitely more costly. I've never quite understood, because I did 9 years of training as an economist, and then I found that the private system in the health system just didn't seem to work as it was meant to. It was out of line with me rather than me being out of line with it. And I think there are complicated reasons why private treatment tends to be more expensive. Some of it is simply because the markets don't work very well in this area. Part of it, though, I think, is that the scale tends to be quite small, and for some of these treatments, a larger scale it can be much more efficient. But clearly here that the Treatment Purchase Fund people did not drive hard bargains, and they felt very weak in their negotiations with private providers, again partly because they had announced the results before they had done the negotiation, and they ended up being weak negotiators in that. And I think you've never got to underestimate the difficulty of public or quasi-public officials dealing with very well-organised commercial organisations, because it's actually an unfair contest often. And in this case, clearly, none of the private providers were shown to be cheaper, but overall they were clearly very significantly more expensive.
Okay, thank you for that. I have Gordon. Gordon.
Thanks, Chair. Thanks very much. And you're very welcome, and very informative document, and some very interesting facts you brought to us. Is there a tendency for health authorities to be managing the waiting list rather than managing the patients?
I think there can be. Again, what the Chair was saying about the importance of the whole journey. Because at the moment the clock only starts ticking at certain points, and sometimes the journey can be very long before you get there. I've been doing a lot of work on epilepsy recently, and one of the things we traced was the journey that got people to the specialist service in the first place. And a lot of these people have intellectual disabilities, so navigating is difficult, and navigating if you're partially disabled is always going to be more difficult. And we found that actually the problems were 3, 4, 5 years earlier before we even saw them, because they had missed the boat on so many occasions on that longer journey. And I think there was a failure. Indeed, all the recording happened only after people had appeared in the system, rather than looking at where they had gone to all the wrong referrals early on, and had then waited to get appropriate referrals and gone around a loop. And it was almost a matter of luck if they ended up getting to the right place. So I think you're absolutely right that it's not easy to get at this as, what is the whole patient experience, but that is ultimately what we're interested in, rather than from when the clock starts.
Yeah, we know there's a concentration on reaching targets. Meeting targets. How that's done is an issue of concern.
I think,
is the patient being put first, or is the patient second in a lot of cases?
I mean, for my sins, I was chairman of the Central Middlesex Hospital when I worked in London, and we had to exactly hit our financial target every year, and we did that. Some years we had more money than we started with, and others we had less money than we started with, but we always met a target because we had a very good director of finance. So, I mean, I think you've got to be careful that if the targets are very explicit, people will find ways that they met the targets, whether or not they did the things that were desirable on that way. So, yes, I think we've got to be very careful, because if you set the targets crudely, you will get crude behaviour to some extent, and that will mean you don't achieve what you're trying to achieve.
The issue of consultants and specialists working privately as well, as most of them are direct employees of the Trust. Is there a real risk of a conflict of interest there?
I mean, there absolutely is. I mean, I've worked in a lot of different countries, but you see it grotesquely in places like Bangladesh, but you actually see it just about as much in Birmingham, because, I mean, essentially, people do find themselves diverted into the private practice of the same individuals, where that is an incentive. And there's been a lot of evidence. It's not everyone who does it, but some people will find a way that you reappear to their profit elsewhere if you've got that conflict of interest potentially there. And I think you've got to be very careful. Public-private mix to the same individuals or the same organisations is typically associated with some people abusing the system to some extent.
So the risk is there.
Yep.
Yeah. And is there a possibility that those people will not work as efficiently?
Well, there's always that possibility, particularly if there is some reward for not doing so. And
Is there any evidence of it?
there is some evidence, well, we saw it at an organisational level, those organisations that got rewarded in terms of, under the waiting list initiative, for example, were found to perform worse in order to keep that waiting list money coming. So, you know, there was clearly evidence that they didn't try so hard because there was an advantage in not being successful.
During their direct employment?
No, this was, I mean, the organisation.
The organisation?
We couldn't observe the individual clinicians, but obviously they were part of that organisation. But there was some evidence that the organisations that were rewarded for failing failed more. And again, I mean, I think we shouldn't be surprised. And it wasn't that they were grotesquely worse, but they were a little bit worse when they were paid more for having failed the last year. So you got more waiting list money the next year.
Okay, thanks very much. Thanks, Chair.
Jim?
I mean, obviously the lessons from the Irish Republic are very useful, and I certainly remember 3 years ago when you were here giving us a fascinating insight into budgets, and that was very welcome. The situation in the Republic is very different in that you have this dual model, and everybody in Northern Ireland gets healthcare at the point of demand. There's no issue. If you want to have private, which is a tiny, tiny proportion of the service here, you can join Bupa and go to the Ulster Clinic, but the vast, vast majority of people don't. So, I mean, can you replicate the lessons learned in the Republic, given the fact that for half of these people, it's the private sector that's effectively paying for a reduction in rates?
I think you can to some extent. I agree entirely that. I think what the Republic offers is some really serious warnings about how not to do things in terms of organisation, because it produces so many of these perverse incentives. So, I would be the first to say it is not a useful model to try and replicate, but it is maybe a useful model to learn from, because there are constantly suggestions of moving towards more mixed public and private systems, and I think it's a good example of where that has shown not to be a very good idea. But in terms of the 50% who are not covered by the private insurance, it's now up to about 55% not covered. They are, I think, very much equivalent to the population in Northern Ireland, where they get the public system or nothing. And so, some of the lessons are, if you introduce a private system, it will be distorting to that. But for the experiences of those who were in the public system all along, these initiatives were really aimed at them, and the problems that arose were problems that I think are going to be generic in that sense.
Useful. Also, as you know, the situation in the Republic up until 2008 was that the economy was booming, money was being thrown at their health service, and everyone was enjoying a boom. Now, was your examples taken before that or during the recession, where clearly there was a lot less money? There's €1 billion taken out of the health service in the Republic since the recession. Was it possible to continue these initiatives during that period?
The initiatives continued. Obviously, like everything else, the amounts of money involved got smaller. Indeed, of course, some of the costs got smaller as well, in terms of the pay cuts and other things that made delivery cheaper. But the Treatment Purchase Fund was started during the boom years and ended 4 or 5 years into the recession. So it was, that covered that area. The Special Delivery Unit came in fairly, pretty much the middle of the recession as a new model. I think in the boom times, many of us felt at that time that a huge opportunity was being wasted, because during that period it really would have been possible to increase the volume of care if they hadn't simply thrown money at it, but had gone for more money associated with very clear improvement in performance required for that more money. And that was very weak. But it comes back partly to the fact that the whole monitoring and information systems have been very crude. It's been difficult actually to enforce any improvements of that kind.
The other thing you said, I found intriguing, you said, I think it's a bit like motorway construction. If you build motorways, cars seem to suddenly appear from nowhere to fill the lanes. Equally, I've noticed with new schools in South Down, if you build a brand new school, children just appear from out of the bushes. It's extraordinary that you do a projection as to the number of children that are available to go to that school, and suddenly there's an extra 50 have appeared from somewhere, and that's because they're attracted by the wonderful new facility. Are you saying that there are GPs in the Republic who have patients who would benefit from knee surgery or whatever, but they're not actually being put on the list because the doctor doesn't perceive there's any likelihood of the operation taking place? But surely that's almost negligent to do that.
Well, I mean, of course, these things are always fine distinctions in that one person's not appropriate is another urgently should be done. But no, I mean, I think realistically, people have often taken the assessment there is no likelihood this person will get treated during the period in which they're likely to benefit. Because after all, in many cases, these are treatments for chronic conditions, typically in older people, and the judgment would be made by the time the person gets the treatment, it won't be worth their while to have it. But I mean, I think it's like we saw with the knee surgery in the Belfast example. Because it was widely available, there was a sort of sensitivity to this is something worth trying to treat, rather than accepting that this is a chronic problem that people live with reasonably well and we won't really bother with referral.
But the logic of what you're saying is that no matter how well we manage the waiting lists, all we're going to do is to prompt people to join those lists because there's the opportunity.
The logic of what I'm saying is that unless you're fairly clear about what is covered and what is not covered in the priorities that the health system has, then that margin will always be interpreted as the GPs observe whether it's possible to get treatment or not. And I think, I mean, we've always been very reluctant to be very explicit about what is and isn't included. You know, there's been a general sort of statement that anything that's useful or important you should get. But countries that have got universal insurance systems tend to have a more explicit listing of what's included and what's not included. And that's never a perfect system, but it is attempting to say those who are less important are less likely to get the treatment unless resources increase, and therefore you can include more things within it. So, you know, if you look at protocols for when people get tests or not, that can often reduce significantly the numbers of tests people have, because so long as a test is free and so long as it's freely available, people will be referred for it, even if, when you stop and think about it, it may not really bring very much value to the individuals concerned. So I think we should never think there is a simple dividing line between useful and not useful, and that will depend a little bit on how easy it is to get access. But my warning is, if you increase the number of people by 1,000 who get the treatment, you will not reduce your waiting list by 1,000. You may reduce it by quite a lot, or you may reduce it by almost nothing. But as I say, in the knee case here, we actually increased it in the short run because suddenly knees became something that people thought you could get something done about it, when previously they thought you couldn't.
Okay, Mickey, you hadn't indicated there?
Yeah, you've actually, thanks for the presentation, you've actually answered one of my questions about the private and the public sector, the same clinicians. But there's also the issue in terms of some of those clinicians actually using health service facilities and tying those up while they're doing their private work. And I've come across examples of that in my own constituency, you know, where for a day they were doing private work and seeing huge numbers of people, and, you know, for relatively short times. Certainly wasn't taking the waiting list down, but it was, from a financial point of view, it was enhancing their budget in that sense. And I think nobody disagrees that it's a complicated issue, a very complicated issue, but like with anything complicated, there has to be a will there to do it. It takes leadership. And you had an example in the South, for instance, a health minister who did a lot less with a bigger budget than they'd done previously with a much smaller budget. So that incentive has to be there. And if it becomes the accepted norm that you have huge waiting lists, then that'll simply continue.
I think that's right. I think a huge amount of leadership is required in the system, but it's required throughout the system. And I think, the evidence really suggests that if you have someone running around with a big stick beating anyone who fails, you'll be successful so long as the person runs around, and you'll be unsuccessful as soon as they stop. So, I think we've got to be very wary of people who know that they can go in. It's the management consultant problem generally at the sort of borrow your watch and sell you the time. It all looks very good for a time, and then it stops. So I think you've got to be very clear that you do need to have the monitoring and the sort of high visibility management of the process, but you've also got to be supportive to the clinicians and managers at the individual facilities. You've got to be working with the GPs around what's referred and how it's referred. You've got to have protocols for what referrals you accept. So it's going through the whole process bit by bit and understanding at each stage you've got to be supportive to sensible practice and appropriate pathways of care to be provided. And that means you have to play a long game, because you recognise that this will be 2, 3, 4, 5 years in getting significant progress. It means that you've got to accept that sometimes you are working with people who are perhaps not the best people in that position, but by throwing them out and bringing someone else in, you'll be pushing the whole thing back by 2 years because they have to learn their way up and so on. So, there are a lot of very complicated judgments have to be made to make it work. And the critical thing really is accepting that you're managing a complex problem and trying to manage it as a complex problem rather than trying to eliminate the complexity, and you find that your simple solutions simply produce more problems that are very similar to the ones you've been trying to get rid of.
I think you yourself made the point, waiting 23 months for a procedure. The time you arrived, it was almost too late in that sense. And people may see a consultant who says, yes, you do need elective surgery or whatever, but by the time you're put on a waiting list and wait, so there doesn't seem to be a prioritisation of the particular problems. You can see them and need something, but it's not done when it should be done.
And the big problem with prioritising, you have to say no to some people. And you know how popular that is. So I think, but we've got to get a bit more grown up and saying yes. I'm 62. I know I don't look it, but I'm 62. And I've got 4 or 5 things that could be treated. And I choose not to have them treated, partly because I'm scared, but partly because it's just not worth it. One of my knees really does give me quite serious problems about 1 day a year. We've got to get a little bit more grown up about that and saying, there are things which, yes, it would be nice if we had unlimited resources, but we don't. So we've got to start saying some no's. And I don't mean by that you take really important problems and refuse to treat them, but we do need to be more sensitive, I think, to where some of these margins could lie. And particularly, again, around investigations, because, I'm Vice Chairman at St James's Hospital in Dublin, and we have the biggest laboratory service in the country. And we do a huge number of pointless tests. And we know that they're largely pointless, but we can't stop them coming. And we just need people to get a bit more sensible around that kind of thing as well.
Thank you.
Okay, thank you very much. That's been very informative, and I think you have left us with a number of messages around the process being complicated, and I think as well the fact that you can't just simply throw a resource or throw fund into one aspect of it as well. So thank you for your time today, and we'll certainly reflect on it.
Thank you. All I can say is good luck.
We're good at the long game.
Well, that's the only one you can play.
Okay, members, thank you. Moving on to item 5, which is the evidence session on the mental capacity bill with the departmental officials. Referring members to the briefing paper on page 16. I think you're all very welcome. We have, and I hope yes, we have Sean Holland, Deputy Secretary, Social Services Policy Group. We have Lisa Truman. Yes, Lisa, you're welcome. Principal Mental Capacity Legislation Unit. Alison McCaffrey, Principal Mental Capacity Legislation Unit, and Paul McConville, Social Services Officer and Office of Social Services. So, you know, folks, the procedure, I've asked you to make the presentation for 10 minutes and then we'll open it up to members' questions. I think, Jim...
Just to go,
yeah.
I'll be in top of the queue.
Okay, fair enough. Sorry, I thought you wanted in at this point. Okay.
Maybe after.
Sure. I'll hand over to yourself then, Sean.
Thanks very much, Chair. Well, good afternoon. Thanks for the opportunity to discuss the draft Mental Capacity Bill with the committee. Members will have our short paper which provides an outline of the updated legislative timetable along with the Department's plans for further public consultation. To begin with, I'd like to give the committee a brief overview of the key provisions of the bill, just to recap on those. As members will be aware, the bill aims to give effect to the major recommendations arising from the Bamford Review. It will introduce for the first time anywhere a single statutory framework governing all decision-making in relation to the care, treatment for a physical or mental illness or personal welfare, including financial matters, of a person aged 16 or over who lacks capacity to make specific decisions for themselves. The scope of the bill is therefore very broad, covering routine matters such as helping to wash and dress a person, right up to the most serious issues like depriving someone of their liberty. It therefore includes the compulsory assessment and treatment of mental disorder, which is currently captured by the 1986 Mental Health Order. That order will therefore be revoked by the bill when enacted in respect of persons aged 16 or over. Importantly, the bill is based on a number of key principles that underpin all of its provisions. It starts by enshrining in statute what is referred to as the common law presumption of capacity. This is the general rule that adults are presumed to have capacity to make decisions for themselves, unless it's established otherwise. The bill also promotes the need to help and support people to exercise their capacity and to make their own decisions whenever they can do so. That means that if a person has capacity to make a specific decision, the bill respects their right to make that decision for themselves, even decisions which others, including their clinicians, may consider to be unwise. And to be explicit, that would include, for example, a decision to refuse treatment for cancer, chemotherapy or what have you, surgery, even life-saving surgery. It will also include decisions about the treatment of a mental disorder, which means that it will no longer be possible to detain a person who retains capacity against their will for the purposes of treatment. In keeping with respect for personal autonomy, the bill will enable people who have capacity to put in place a new lasting power of attorney to make not only financial decisions on their behalf, but also health and welfare decisions, should they lack capacity to do so themselves at some point in the future. Where it's established that a person lacks capacity using the test provided for in the bill and no alternative decision-making arrangement has been put in place, but a decision in relation to a person's care, treatment or personal welfare needs to be made, the bill puts in place a new statutory decision-making mechanism, and this really is the very heart of the bill. Rather than giving certain people statutory powers to intervene in a person's life, which is what currently happens under the Mental Health Order, the bill adopts a different approach. It puts on a statutory footing the common law doctrine of necessity insofar as it applies to acts in relation to care, treatment or personal welfare. This doctrine is currently relied on by many people who work with or care for people who lack capacity to make decisions for themselves. In broad terms, it provides protection against civil and criminal liability as long as you are acting in the person's best interest. This approach isn't unique. It follows what's taken place in terms of the Mental Capacity Act in England and Wales. What is unique, however, is that these core provisions have a wider application than those in England and Wales, in that they apply to all acts in connection with a person's care, treatment or personal welfare. They therefore cover compulsory assessment and treatment of mental disorder, which in other jurisdictions continues to be dealt with by separate powers under separate mental health legislation. I suppose when you're doing something that is unique, it's very reasonable to ask the question, why are you taking that approach? And in this case, it's an outworking of the Bamford vision to reduce stigma associated with separate mental health legislation. And I think that's what really makes this legislation groundbreaking and eagerly awaited by stakeholders and commentators. And that's not just locally, but in other parts of the world as well. What is also unique about the bill is that it goes well beyond equivalent legislation elsewhere by requiring additional safeguards to be put in place where the intervention is serious. These safeguards are designed to protect the person who lacks capacity and, importantly, if they're not complied with, the person intervening can be held liable for the actions that they're taking. Let's move on briefly to the legislative timetable. Considerable time and effort has been applied to developing the key aspects of the Bamford Review proposal for a single new legislative framework over the past number of years. As reflected in the Minister's letter of the 9th of December, the core civil provisions of the new framework have now been drafted and significant progress has been made in relation to the criminal justice aspects of the framework. This progress has been informed by the outcomes of 2 previous consultations by the Department in 2009 and 2010 and a public consultation on the criminal justice issues by the Department of Justice in 2012. Indeed, getting to this point has been a collaborative effort involving many people and organisations. And the corollary of that progress, however, is that more drafting time has had to be built into the bill's legislative timetable. Members will be aware of the recent decision by the Health and Justice Ministers to bring forward the public consultation on the draft bill to March of this year. It's intended that the consultation papers will include the core civil provisions of the bill as currently drafted and a further policy statement by DOJ on criminal justice issues. There will also be an update on children's issues. This revised timescale will ensure that stakeholders are given the earliest opportunities to consider the core provisions of the new framework. It should also allow the drafting of the remaining sections to be finalised, thereby maintaining progress towards the introduction into the Assembly in early 2015 with a view to enactment before the end of the current mandate. Now, finally, I'd like to turn to the issue of under-16s and why the Department position has not changed in relation to under-16s. As I mentioned earlier, the bill enshrines in statute the common law presumption of capacity in adults. This presumption, on which the entire bill relies, simply cannot be applied to all children. I think it's really important to explain to the committee what a presumption of capacity in children would mean. For example, a doctor would have to assume as a starting point that a 2-year-old would be competent to consent to treatment. A social worker would have to assume that an 8-year-old had capacity to decide that they no longer wish to live with their parents. A dentist would have to assume that a 10-year-old had the capacity to decide whether or not to have a filling. Not only would this not make sense, but it would also fundamentally undermine the role of parents in making decisions for their children, which is central to the working of the Children Order and reflected in our age of majority legislation as well. We need to be clear, this bill is targeted at adults who lack capacity because of an impairment or disturbance in the functioning of the mind or brain. For children, the issue relating to capacity is more about a developmental issue, a lack of maturity and indeed an absence of life experience to help inform their decision making. Therefore, whilst we hold dear the rights of adults to make decisions that may not be in their best interests, the position is fundamentally different for children, and this bill simply will not work for them. That's not to say that the views of children should not be heard or that they should not be able to participate in making decisions. But at the end of the day, children are children, and we owe them a greater duty of care because of that status. This position is in keeping with the UN Convention on the Rights of the Child. Put simply, there is a different and much more complex legal framework currently in place for children. Indeed, this is why the capacity legislation in other parts of the UK does not apply to under-16s. In fact, the Republic of Ireland has gone even further by not applying their draft capacity bill to under-18s. The Department believes that emerging capacity in children should be given careful consideration, but in the context of a separate project. Such a project would be a substantial undertaking in its own right, and given the Department's current focus on this bill, it is therefore likely to be a commitment for inclusion in a wider Children Order-related review for the next Assembly mandate. The Children Order is the right context in which to consider these complex issues, as this is where the concept of parental responsibility is currently enshrined. Also, let's not forget that the Children Order will continue to apply to all children, defined under that order as persons under the age of 18. Importantly, this order requires the child's welfare to be given paramount consideration. It also recognises that children should be given a voice in what happens to them and gives opportunities for working in partnership with children as far as their age and development allows. In addition, under common law, a child who is GILIC competent can consent to medical treatment. However, this is diluted as parents can consent on the child's behalf where they do not consent. Another example of just how complex this area of law is and why any changes to this existing legal framework should be given careful and separate consideration. Pending the outcome of that separate project, legislative cover, however, is required for the small number of under-16s who require compulsory assessment and treatment for a mental disorder. As the mental health order already provides important safeguards for these children, the Minister has decided that it should be retained as a temporary measure for this purpose. In addition, the Department is currently working closely with children's stakeholder groups to inform the proposed amendments to that order to enhance the safeguards in it, drawing where appropriate on those available in the mental capacity legislation for children aged 16 and over, subject to the same intervention. Indeed, to put it simply, we're open to consider any proposal brought forward by any stakeholder group that would better protect children under the retained provisions of the mental health order. So, in conclusion, I hope our presentation and briefing paper have helped outline our way ahead, and we're now obviously very happy to answer questions.
Okay, thank you, Sean, for that. I mean, it is an important piece of legislation, and I think all of us are actively trying to get the correct, robust and protective fit. But I'm just interested in the Bamford Review had, very clearly indicated that the mental health order was not fit for purpose, and it highlighted a number of failings of the order, including the fact, and you've alluded to that it didn't comply with human rights standards. So how then can the department justify a proposal to retain that order for under-16s, given that it's at conflict with the recommendation of Bamford?
Well, I think that it's important to place the Bamford work in context. It was a large piece of work which pointed in the direction of travel that it felt should be taken in relation to a number of issues. And things move on. We considered the issues raised by Bamford in greater detail than could have been done at the time when the Bamford vision was set out. Now, when it comes to under-16s, we are proposing to retain the mental health order. You're right by saying that there are flaws in that order, which is why we're undertaking the wider exercise. But we're retaining it on a temporary basis until we can reach a more permanent review of the situation for children within the context of the Children Order. And I think that that's been welcomed by a lot of interested parties, particularly rights groups, who recognise that there are advantages to gathering together issues that relate to children into a single piece of legislation. And we are looking at ways of introducing additional safeguards not currently available within that period when we have the provisions of the mental health order retained, which will address some of the reasons why the mental health order was identified as having deficits in terms of human rights. And as I say, we've no fixed views about that. Anyone who comes to us with a concern about how a vulnerable young person needs additional protection and has a suggestion to us as to how, during this period of retaining the mental health order for those young people, we can enhance their protection, we've said we will do whatever can be done. If you can demonstrate to us that this protection can be is required and can be provided for, then we're very, very open to that.
What concerns me is twofold. The Children's Order, which you're referring to, is almost 20 years old. Mm-hmm. And that in itself brings challenges when we're looking at particularly the horrific issues around things like child sexual exploitation. Is the order itself out of date? And now we seem to be saying the department are placing a lot of emphasis back on it. That's the first thing. But we're saying an order which you have admitted is flawed. But we're going to enact this in some sort of temporary measure to provide legislative cover. What do we mean by temporary?
Well, I think that you make reference to the children order being, it goes back to 1995. It's been around for some time. There are many aspects of the children order which remain fit for purpose, and we should, I think, actually be, we should recognise the many children's lives which have been enhanced and protected by the use of the children order, and also the greater voice it's given to parents and family members in some very difficult circumstances that weren't allowed for in the legislation that preceded it. But it is something that I think does require a change. You've referenced child sexual exploitation. I think that's one of the issues that we would like to consider in reviewing the children order. But that same issue of child sexual exploitation is one of the things that would be of great concern were you to extend the mental capacity legislation to under 16s. I think that we already know that we've had significant difficulty with young people who are definitely capacitous, putting themselves in very dangerous situations against the advice of people who are there to care for them. Now, if you were to extend the mental capacity legislation to under 16s, they would have a legal right to place themselves in certain situations without parental or carer intervention. And that, I think, would be a really concerning situation.
Sorry, in relation to temporary?
Temporary children, how long we're going to...
What does temporary mean?
Well, certainly the work to address a reform of the children order would be substantial, particularly because this would be the first time that we haven't simply followed England's lead in terms of children's legislation. I mean, the 95 children order in Northern Ireland was more or less a case of us taking a piece of legislation that had previously been enacted in England and Northern Irelandising it. That wouldn't be the current position. Our proposal to look at children order, a review of the children order, is not following an English situation at all. We'd be starting from scratch ourselves.
Well, if something's temporary, does the department have a preferred permanent solution?
The permanent solution would be to bring forward in the next Assembly mandate a new children order. But, I mean, that will be a complex task requiring significant resources. I'm aware of the time, as the committee will be, the time and the resources that have had to be dedicated to the mental capacity legislation. And certainly that's been difficult because it's groundbreaking. But in terms of scope, reviewing the children order would be as big or a bigger undertaking. So it would take time to do it.
Okay, well then, just finally, is there a risk that for under 16s we're using a piece of legislation that in your own words is flawed?
That's why we've said that we will enact in the retention any additional safeguards that people feel are necessary to protect the interests of vulnerable children. That, you're right, there is a risk, and the action we're taking to mitigate that risk is to put in place additional safeguards for under 16s.
It's still a risk. Okay, I know a number of members have indicated. Jim first.
Your colleagues are clearly quite offended. They haven't had a chance to speak at all, Sean.
They're going to get plenty of chance, Jim, as we get into the technical
angst in
detail.
their faces. So maybe they'll want to take this on. I use an adage that if I absolutely commit myself to something, I'll say £500 to your favourite charity if I don't deliver by a certain date. Are you prepared to give £500 to your favourite charity if you don't deliver this by the end of February?
If I were able to control all the variables, I would happily make it £1,000, Jim. Unfortunately, there are a number of things that are not within my control. So while there are many charities who I would very happily support, I wouldn't want to make it contingent on this bill.
Could I suggest the Jim Wells Benevolent Fund be added to that list?
Is that a regulated charity, Jim?
But what I would say, Sean, we have had quite a few dates and quite a few false dawns.
Yeah.
And you've sat in that chair many occasions and said, hand on heart, it's going to come. And those dates have all passed. And now you're giving us a commitment that you will have a written ministerial and executive agreement, and that the word executive does worry me, because that is like a black hole when stuff goes in there. But you're saying there's going to be a ministerial and executive agreement to consult on the core provisions by January or February 2014. This is January 2014. Where is it?
Well, I'd have to check Hansard, but as far as I'm aware, the commitment I've given when I've sat in this chair is that this legislation would be would be brought forward in this mandate. I know timetables have been provided previously, but I think that's the only commitment I've given. In terms of, January, February, we're hoping March to actually commence consultation. And at this point, I'm going to hand over to Lisa, who can take you through the detail of the legislative timetable.
Yes, as Sean said, we intend to consult in March. That's on the core civil provisions of the bill and an update on children. And I know the Department of Justice will also issue a further policy statement on criminal justice provisions. So that takes us to March, and then it will be our intention to analyse responses early summer and introduce the bill into the Assembly in 2015.
That's January 2015. That's cast in stone. That can't be moved.
That would be our intention.
Right.
It's cast in stone in that we have to get it to that point for the legislation to be brought forward in this mandate.
Yes, because enactment's March 2016. Now, so, if there's any slippage of all of that, then you're in real trouble.
Yeah.
In fact, you would be in deep trouble had the Assembly mandate not been extended for a year.
I would acknowledge that.
You wouldn't have met the target at all.
I would acknowledge that.
You're not going to get an extra year, in the future. So, it would be an awful pity to go through all of this procedure and then for the whole thing to collapse because you didn't get it through in time. I realise that a lot of the donkey work will have been done, so you're not picking up from fresh in the new mandate, except that an awful lot of work will have been done by that stage, so it's not entirely lost. But I see this as the most important piece of legislation that the committee is dealing with in this mandate. I also see it as one of the most complex. And I really wouldn't like to think that that Mrs. Truman will be back at some stage in the future saying, sorry, but it's slipped for another 6 months.
Neither would I, and that's why the department has committed significant resources in terms of the bill team bringing forward this legislation, more resources than I've ever seen placed behind a piece of legislation. But I also have to be honest with you, there are some things are beyond our control. This is a cross-departmental initiative, so we're working with 2 departments. So Justice are dependent upon us and we're dependent upon them. We do require various stages involvement of the executive, and I wouldn't describe it in the terms you did, Jim, but certainly it provides challenges sometimes to get things through the executive within a certain time frame. And then the other thing, as I think illustrated by the Chair's opening questions, this is really complex, and there are a broad range of stakeholders who have had to be involved in this work, and it's been slow.
And is part of that problem that Justice are lagging behind health?
I wouldn't say that. We're working very well with Justice, and both of us are committed to this time frame.
Okay.
Okay, Kieran.
Chair, I'm delighted to hear your commitment once again, because this is, as you said, groundbreaking legislation that we want to see before the end of the Assembly term. Just a couple of quick questions. How will the Department ensure ongoing engagement with key stakeholders during the drafting and advancement of the bill? And finally, does the Department have a clear legislative window to complete the bill, given other legislation that builds up towards the end of an Assembly term?
Okay, I'll answer the first part of that question, and I'll ask Lisa to address the second part. Engagement with stakeholders throughout the process. I think that this process has been characterised by the way stakeholders have been engaged. And that, again, going back to the Chair's opening remarks, probably relates to the fact that it came out of the Bamford work. Because Bamford was a very inclusive process, and a very wide-range process. That engagement was set up and started and has flowed from there. And we, obviously, consultation is part of the engagement. We intend to, as part of the consultation exercise, do targeted consultation exercises. So again, stakeholders will have specific events within the consultation period. And then, of course, when we get into the drafting stage, well, I'm sure the committee will play its role in ensuring that stakeholders are engaged, because when we're at that stage of amendments and questions, that'll be the voice for those stakeholders by using committee members to engage with the bill.
Okay.
This is the second part, which related to the legislative window.
Sorry, can I just clarify that
Yeah.
question? The legislative agenda within this mandate?
To complete the bill, given other legislation that builds up towards the end of its assembly term.
Well, it was-
That's the problem. We want to make sure that we don't fall at the last hurdle.
Could I just add to that it's traditional in this place that legislation suddenly
Absolutely.
arises from nowhere and has to be rushed through.
Yeah.
And the last few months of this normally is awful place because there's so much that has to be got through. Are you going to get caught up on that?
Well, I'm sure members will be aware that we have suggested to the Health and Justice Committees that we have an ad hoc joint committee, and I know it's the intention to begin consultation with that committee after the consultation process. However, it might be prudent to bring that consultation with the committee forward, because obviously we would be more than happy to bring the committee as soon as possible just to ease the passage of the bill. But you're right, I mean, we have from January 2015 through to the end of the mandate, and it will be challenging.
But you're committed to seeing
We
it
are
through.
committed.
Well, we'll give you 100% support and hope it comes through. Thanks, Chair.
Okay, thank you, Kieran. Nikki?
Yeah, thanks for the presentation. Just a few points to make. Would you accept the decision of the Department to exclude under 16 from the proposed bill? I suppose it leaves arguably the most vulnerable group, children under 16, and their primary advocates, their parents, outside the scope of what might be considered progressive legislation. Because the Department have decided that children and their parents are best served by retaining what again would be considered out, and you have admitted, archaic legislation. And just, you can correct me if I'm wrong on the figures, it seems that currently less than 0.5% of children being treated in mental hospitals are formally detained. So therefore that leaves 99.5% of children are inpatients on a voluntary basis without legislative cover. And surely that couldn't be considered satisfactory. And, you know, when you go on to consider paragraph 11 in your presentation, the Department says it is seeking legislative cover for the small number of under-16s, and those are the 0.5%, I presume, who require compulsory assessment stroke treatment of mental disorder. That means that the majority of children will not be subject to that additional legislative cover. Now, you know, there's going to be children left for quite a long time without that legislative cover, because if you're doing a review, and the Children's Order, because I was working in the voluntary sector and that came in the mid-90s, that was a huge piece of legislation, you know, and took a long, long time to actually come to fruition. And even now would still be regarded as fairly complex legislation. So, you know, it seems to leave the most vulnerable group outside the scope of progressive legislation, you know, and I don't understand why that hasn't been addressed, because what really you're saying is we're putting this into place and it's going to cover X number, but there's going to be a number who are probably the most vulnerable left out. That cannot be right. It can't be satisfactory. Whatever way you want to dress it up.
Well, if I can respond, the first thing to say is that I don't believe it would be progressive legislation to extend it to under-16s. I think it would be dangerous legislation, and I think it would be against the will of most people in Northern Ireland who have a very strong commitment to family values and particularly respect the role of parents in decision-making for children appropriate to age and stage. And we are not alone in that position. No other jurisdiction anywhere in the world has tried to extend this kind of legislation to under-16s, and I believe for the very reasons that we don't wish to. That does not leave children without any protections. The Children Order, which applies to all children under the age of 18, affords them protections. Within the Mental Health Order, albeit that it is flawed currently, there are protections. In retaining the specific provisions of the Mental Health Order, we're willing to look at any additional safeguards that anyone can point to us and say, we think there's a gap for this vulnerable child, so you need to do this. We're anxious to have those conversations and are having those conversations. And that would extend as well to those children who, as you rightly point out, Mickey, are very vulnerable and aren't actually covered by the legislation. In our discussion with children stakeholders, we have said, please, we will also consider looking at what we can do to enhance safeguards relating to voluntary patients, children who are detained on a voluntary basis. So we will try and address that issue in whatever way people come to us with practical suggestions. I'm looking to my colleague Paul. Is there anything you'd like to add?
Within the existing system, there are examples of good practice where safeguards are in place for children who are voluntary patients. There's consultation with their parents and indeed with the young people themselves, and advocates, if there is a conflict of interest between, or a perceived conflict between children and parents' positions, independent advocates can be used to represent the views of children and young people. Those who are in inpatient facilities would be consulted very regularly about their experiences on ward rounds, and indeed any child who resides in hospital for 3 months or more must be notified, and the provisions for looked after children, including the looked after reviewing process, is then enacted. So there are a number of existing safeguards within the Children Order. However, it's the question of detention, then the Mental Health Order would apply.
Could I just make another point in relation to consent and voluntary in relation to under-16s? Because it seems that compliance to the wishes of adults, even when they believe they're acting in the child's best interest, isn't consent necessarily. And obviously parents and doctors have a role in decision making for children, but it seems that there does need to be safeguards, whether they are classified as voluntary or involuntary patients. So, you know, the wishes of adults, it's in terms of compliance, it's not necessarily consent.
No, I mean, an adult or a parent can, on occasions, unfortunately, as this committee is only too well aware, act in ways that are not in the best interests of a child. And it is important that safeguards are in place to prevent that. And that is why we are engaged with the children's stakeholders to identify any measures that can be introduced that would mean that no child under the age of 16 is in any way less well protected than a young person over the age of 16.
I'll just finish off by saying the purpose of changing the legislation is because it's inadequate. So inadequate legislation is still going to apply to those children until the Children's Order and all of that is reviewed. So there's still going to be a vulnerable group left without the same protection. So obviously there must be some sort of an equality issue there as well, because you have a group of children who do not and will not have the same protection as the majority of children.
I think that there are a couple of points. Firstly, there's a choice. I mean, the choice is that do you try and extend this legislation to under-16s with all the consequences that we've outlined? Clearly, that's not a choice that's acceptable to the department. And then you say what is practical. And it would not be practical to undertake a review of the Children Order simultaneously while bringing forward the mental capacity legislation. It just physically could not be done. So, you rightly say, Mickey, there are vulnerabilities there. You then put in place whatever safeguards are required to address those vulnerabilities. That's what we intend to do. I'm looking to Lisa and Alison. Is there anything that you would add to?
No.
I'll just say I remain to be convinced. Maybe leave it at that.
Okay,
Thanks.
any other comments? Okay, thank you for that information. I suppose from the committee's point of view, cleared something that we will be closely and actively working through in relation to whatever ad hoc committee is formed post the consultation. I think the issue does remain around the under-16s and the fact that we still ultimately are talking about a mental health order which is recommended to be flawed and to be non-compliant with human rights in some regard. So there are real challenges there. I think as well the department, you know, while saying on the one hand we look at whatever suggestions or protections are brought from sectors, need to be doing much more in relation to particularly vulnerable children and particularly under 16. So I'll leave it at that. You've heard our questions today and we'll continue that engagement and we'll work through the scrutiny process. Thank you for your time.
Thank you very much, Chair.
Thank you. Members, item 6 is a statutory rule. The General Ophthalmic Services Regulations, if I say that right, 2013, can refer members to page 23 for that. The committee had considered and approved the SL1 for this rule at its meeting on the 11th of December, so can I ask the members' content?
Great.
Therefore, the Committee for Health, Social Services and Public Safety has considered the amendment regulations and has no objection to the rule subject to the report of the Examiner of Statutory Rules. Item 7, members, is the Forward Work Programme. Referring members to the Forward Work Programme on page 29. Advising members that the draft terms of reference for the committee's review on TYC and older people, as agreed last week, will be discussed at next week's meeting. Members comfortable with that? Under matters arising, refer...
Will that be 3 sessions then next week? Or?
Is there 3 sessions in this?
That raise.
Well, that's not really going to be a session, that's just a discussion, because it's just a terms of reference for us to sign off on or otherwise.
So a bit of briefing from Reyes here.
Yeah, but the item I'm pointing to here in terms of the
Oh, right.
older people won't be a briefing session.
Right, okay, thanks.
Okay. Matters arising, item 8.1 on page 31 is a draft committee response to the OFMD-FM committee on the work the committee did in relation to European issues last year and our plans for this year. And I'm just asking members if they're content with the responses as drafted.
Right.
Okay. Moving to item 8.3 on page 34 is a DFP memorandum on the report from the PAC committee regarding the fire and rescue service. The Public Account Committee will be receiving a briefing on this at its meeting on the 5th of February, and it will then decide if it's taken further action. The clerk will liaise with the PAC to learn the outcome of the discussion, so are members content to note that
Great.
for the moment? Thank you. Under correspondence, members, item 9.1 on page 45 is a letter from the Minister announcing public consultation on the domestic and sexual violence and abuse strategy, and suggesting that the committee seeks briefing from officials once the responses to the public consultation have been analysed, and this is likely to be in May or June. Members,
Yeah.
to note that. Asking members to note item 9.2 on page 46, and item 9.3 on page 47 is a letter from the Public Health Agency asking the committee to sponsor a smoking cessation service event. It is organising on the 29th of January. Are members content to sponsor?
Great, you happy with
Thank you.
getting involved?
Members to note 9.4 and 9.5 on pages 48 and pages 50.
Right. Right, yeah.
Item 9.6 on page 51 is correspondence from the Committee for Regional Development regarding its inquiry into the benefits of cycling on the economy. The inquiry's terms of reference cut across a number of departments, obviously including health, and they've written to the relevant committee to ask if we're content that they undertake this piece of work. So are members content? Item 9.9 and 9.10 on pages 69 and 71 are letters from Margaret Ritchie MP and Down District Council about the changes to the opening hours at the A&E and the Down Hospital. The matter was raised by the committee last week by Chris Hazard, MLA, and the committee had agreed that it was a matter for constituency representatives to take forward.
Madam Chair, I'm slightly uneasy with this. I have to say that the MP has approached me in her usual shy, retiring self about this, and has been quite heavily lobbied. And I think this raises a much wider issue than just Down and Lagan Valley. It raises the whole issue of the stress that our acute hospitals are under due to lack of middle-grade management doctors. And therefore, I understand your concern that this could be contrived as being a purely constituency issue. I know that would maybe set a difficult precedent. But I think if it was part of a wider look at this issue, that the big teaching hospitals don't seem to have trouble attracting staff, but this is something I've seen all over the province of hospitals struggling to maintain A&E because of the absence of A, consultants and B, middle-grade doctors. And I think it's important we address this before it starts to afflict all the hospitals outside the Greater Belfast area.
Yeah, sorry, just on it. I agree, Jim, and we had raised this last week and agreed that part of the way to try to address this was have an evidence session with NIMBDA, yeah, so that we could get the accurate sense of things like recruitment and whether that is targeted enough or whether there are gaps, and that will be some way to try to flush some of those issues out. So that is agreed that we proceed on that. But you're right, there is a wider issue there.
Would it be useful to have a practical example from somewhere like Down District explaining the difficulties as part of that hearing?
Yeah, why not?
But I'm conscious, Jim, as well, and the deputy chair will be very vocal on this at every given opportunity. I don't think the committee's role is to get advice from public reps in relation to some of these issues. We're trying to have a consistent approach to all of this. So I'm just coming back at you on
I have to
that.
admit, it was a good try.
Oh, absolutely. Fergal wanted in.
But yes, Chair, and clearly there is an issue in Down, but that has been part of it. Stepping and staring through the depletion of resources there, which ultimately has led to, we believe, a situation where junior doctors or doctors for A&E aren't being attracted to there because the capacity is no longer there. There's no longer elective surgery. There's no longer a teaching facility, etc., etc. And all of that is fitting into a wider jigsaw where services are closed elsewhere. They're being closed by a trust, and the minister claims he's opposed to it. I mean, that's a fundamental for this committee, that it should be taken a look at who's ultimately responsible for the decisions being made in the health service. It's been described, Jim described it last week, he reflected on a phrase that I used, which was the tail wagging the dog, but he was saying it was a BMA tail wagging the dog. We believe it's a trust tail wagging the department's, wagging the department dog. So what we need to see here is a committee taking a strategic look at how at decision making within the health service overall, because we have small decisions made somewhere as a result of pressures put on organisations, and then it's backing up into other pressures, and we saw that in the Royal. I know some of the figures are disputed, but nonetheless, we have. When you see a pattern, you see a pattern, and we should either accept or reject that pattern, at least interrogate that pattern from a committee perspective to see how decisions are made.
No, I agree, Fergal. I think what we're attempting to do is look at interrogating the context of that pattern. And I think part of which will allow us to do that will be having that evidence session with the Medical and Dental Agency, because I could make a similar statement in relation, for example, to the Western Trust, which apparently there's 5 million spent on locums because they can't recruit junior doctors because of infrastructural deficits or people not wanting to travel. So there are issues around training and recruitment that I think this organisation will allow us collectively as a committee to flush out and expose and decide a course of action around it.
But ultimately, I think we should be asking ourselves whether the strategic direction is right. What we have here, as research into TYC confirmed, major pressures in the public mind around accident and emergency, and major pressures in the public mind around community care. What they've done is they appear to be stripping money out of accident and emergency while not yet bolstering the community care bank. So we've ended up exaggerating the two problems. There's a fundamental disconnect here, or a fundamental problem with the strategic direction of all of this.
And I think part of the work that we're doing currently around TYC is trying to equip ourselves with the evidence around that, which will allow us to make recommendations. I would suggest to the member that we have that evidence session, that on the basis of that, rather than probably facilitating individual trusts for evidence or public representatives, that we decide on a course of action which is around recommendations, and that we seek a briefing directly with the Minister or with the Department.
Madam Chair, this issue came up 3 years ago with the Mid-Ulster Hospital, and the compromise was that a delegation came up from Mid-Ulster and an ad hoc informal meeting was held, which I organised and invited other MLAs, not outside the committee. It's just a meeting was held and committee members are invited to it in exactly the same sense as any other meeting would be held. And, you know, if you as chair and I as deputy chair were able to attend that informal meeting out with the committee, it gives that group an opportunity to express their concerns to the committee, albeit indirectly through individual members.
Well, I suppose, I mean, it's up to individual members what they do outside of the committee's remit, and I think we're happy to discuss that as individuals. I do think that the committee have taken a very clear and, in my view, correct approach, rather than being dragged around on a number of issues, that we take a strategic approach. And in my view, the best approach to take to this currently, and that may shift, but at this stage, I think is get the evidence session from the Medical and Dental Association. But happy to discuss, Jim, or with anybody else, about what we can do outside of the committee, if people are happy enough with that.
Well, I mean, crucially, if it was a slot that you were available as chair, because I think they'd want to see you, obviously, but it would be totally out with the committee.
Okay. Well, happy to discuss that with you. Okay, we're comfortable enough that we'll invite, as part of this wider issue around A&E hospitals, that as agreed last week, we proceed and have the evidence session with the Medical and Dental Agency as the first step. Okay. Thank you. I'm asking members to note then items 9, 11, 9, 12 on page 72 and 73. Item 9, 13 on 81 is an invitation from the Confederation for Health and Social Services to attend its conference on the 5th and 6th of March. Members did attend last year's conference in Derry and found it useful, probably in terms of getting a sense of the implementation of Transforming Your Care. This year's programme is again centred around TYC. I'm suggesting again that the committee attends the conference. It's in Belfast on the Wednesday in place of the formal committee meeting. I think it was useful for people who attended last year, and that the committee takes a place at that. Items 9-14 on page 87 is a letter from Friends of Chestnut Grove seeking a meeting with the committee about the closure of residential homes. The committee had previously referred the group to constituency representatives for support. Are members content to reinstate this position?
Great.
Okay, item 10 is any other business. Do members have?
Sure.
You're in, yes.
Yeah. The future of the consultant orthopaedic foot and ankle surgeons based at the Musgrave Park Hospital. There's concerns regarding the future of that facility, and I would propose that the committee writes to the Health Minister seeking what the future holds for it, because it can affect us all. There's concern that they haven't been consulted properly on any changes, and there's no training being brought forward, and we could end up like what is happening in A&E with no surgeons or no practitioners to provide the service, and perhaps maybe we could even invite a consultant from the foot and ankle from Musgrave to address the concerns of the committee.
Well, I think my understanding is, Kieran, thank you for raising it, is that there is some ongoing work, or whether it's a review. I'm not completely au fait with the detail, but I agree we can seek a view from the department, an update in relation to the work that's ongoing, and then agree or decide or reflect on what that response is.
Okay.
Okay.
Thank you.
Thank you for that. Date, time and place of next meeting is the 29th of January at 2 o'clock in the Senate chamber. Thank you, members.